All right, today we're going to show you a little bit about how we do a general anesthetic for a facelift patient. This young lady is 46 years old, and her health history is unremarkable for anything. So first step we're going to do is hold the mask over her nose and mouth and pre-oxygenate the patient. Just let her breathe in, 4 or 5 times, 6 times. Basically, we're just trying to get rid of the nitrogen in her system and raise the expiratory oxygen up and above 90%. As you can see, we have propofol in line, and the muscle relaxants we use are just dependent on the case. This is a pretty straightforward case. I'm not worried about any airway issues, so it's going to just be used rocuronium. So here we go. The assistant hands me the propofol, and I am administering about 150 milligrams of propofol while the patient breathes. The patient has already received 100 mics of fentanyl. I typically administer that upon the successful completion of the IV, which is in her left arm closest to myself and the anesthesia machine. So we're just letting this propofol take place, or take effect, and we'll wait until her respirations cease. And then I will assist her with a little bag valve mask inhalation just to check her airway patency before I administer the actual paralytic. And that just gives me an idea about not so much if I have an airway, but if I were waking the patient up, would I have difficulty masking her if she were to have some type of laryngospasm or bronchospasm or some other airway issue where I needed to assist her in ventilation. So you can see that I gave her a couple positive breaths and everything was good. So I'm going to administer the rocuronium, which pretty much standard. I give 50 milligrams. And we'll wait for that to take effect. It typically takes about 1 to 3 minutes for the rocuronium to kick in enough to where the cords are relaxed, which will allow me or facilitate my ability to insert an endotracheal tube through without any issues. So right now I'm just giving her some positive pressure ventilations, just working out, getting out more of that nitrogen, breathing for her. You can see we have adequate chest rise. She's an easy mask, so no concerns here. If you did have concerns, then you could put in a nasal airway or even an oral airway would be sufficient to just allow you to breathe easier for her. Most patients don't require that. I rarely ever use any adjuncts to mask ventilate. So as we give that, we will then move on to the next phase, and that is the insertion of the endotracheal tube. So you can see here I got a laryngoscope. I'm using a Miller 2, and obviously we just want to be very careful. One of the number one instances during a DVL is dental damage, and we don't want to have that occur. So we just kind of insert that blade gently extend her neck so that we have a clear view and making sure that we're staying off the teeth. It might appear that it's coming back further, but I can promise you there's no pressure going on our front teeth. All right, and I'm just forming a hockey stick type maneuver while inserting the endotracheal tube, and the assistant's going to pull out the stylet, which a lot of times kind of facilitates advancing the tip of the tube just a couple more centimeters between the cords into the proper location. At this point, I'm going to inflate the balloon, the pilot balloon, to the adequate pressure to seal it off so we can provide positive pressure. I actually witnessed the the tube going through the cords. So what I do is I actually inject 100 milligrams of lidocaine to numb up the airway and facilitate in preventing reflexes, the airway reflexes, which would result in like bucking or gagging on the endotracheal tube. This I found has been very successful over the years. Before I used that, when we would turn the head, because we were turning the head so many times when we were going from side to side, sometimes that irritation in the trachea would cause the patient to buck. And since I started doing the lidocaine as an adjunct therapy, then I really haven't had any issues with that, and the patient has actually done quite well. And very, very rarely do we ever have a patient buck while being intubated. And part of that is because I let that paralytic wear off. It's the rocuronium, and then I just have the patient breathe on their own spontaneously for the rest of the case. You can see here now that I'm actually tying the endotracheal tube in to the front teeth with dental floss. Because the surgical area is on the face, typically Dr. Niamtu doesn't like to have that tape over there since he's working in that area. So I secure the tube with some dental floss there. It works very well, keeps the tube secure, and also allows us to do the surgery without any interference. I'm using a reinforced tube that allows for some flexibility in the tube and prevents